Hello, my zebras and spoonies. Thanks for coming hanging out with me today. I am glad that you were here. Today, I am going to be talking about the process that a provider goes through to give a patient a diagnosis. So that would be a doctor, a nurse practitioner, someone like that. I've seen this topic come up fairly often in several of the groups that I'm in, and I think that it would be helpful for patients to have a better understanding of the process and thinking that goes into the diagnostic process. Because many times people will express frustration as to why they aren't actually diagnosed with something in particular, or why a provider doesn't pursue a particular diagnostic path. So I want to talk about what I've personally seen as a nurse in my career and how providers go through this process. So the first thing to know is that there are rules for making a diagnosis that a provider is supposed to follow. And these are the standards of practice that dictate a certain set of signs and symptoms that need to be present in order for a patient to actually be diagnosed with something. So this is important because it ensures that there are standards for each diagnosis and that every provider is using the same criteria when diagnosing people. And this is what gives diagnoses actual meaning. It's what makes it so that when you see a diagnosis as a healthcare uh, provider, a nurse, a doctor, we understand a general idea of what's going on with this person because of that diagnostic label. So these labels lose meaning if providers are not following the rules for diagnosing people with that diagnosis. It's also important because insurance companies require justification for payment. And this means that the diagnosis and the symptoms that you're treating have to match and make sense if you want to be able to get paid for your services. You can't just be like, "Oh, I'm going to do this thing because I think it's a good idea." You have to be able to justify the care that you're giving a patient if you want to be paid for it. So, this adds a bit of a challenge because people are complex and don't always present the ways that diagnostic criteria say that they're going to. And this is often because that research that's been done on illnesses has historically been done on white males, which largely limits the perspective of illness. It's also just because there are always a certain number of people that are outliers and won't present in the classic way. Because of this, there is a prescribed method to go through to diagnose a patient with something that is not presenting in the classic way. But it is more difficult and it can lead to payment issues. And it's just generally the standard of practice is to diagnose people based on that prescribed set of this is what the diagnosis is. So that's something to keep in mind. The next thing to know is that there is a method to the diagnostic process. The first step is data collection, and this is getting your report of what's going on, reviewing the medical record, doing a physical exam, and then that data is compared to the diagnostic list in a provider's head. And from that, they generate what is considered the differential diagnosis. And this is the list of things that a provider thinks could be going on. So it's all of the possible diagnoses. So there's a couple things to understand about this. The first is that you're limited to what a provider knows. You're never going to be diagnosed with a disorder or a disease that a provider has never heard of. That's just the nature of it because that differential diagnosis is a database in their brain. I mean, so that's the first thing. The other thing is that it's based on loosely on statistics. It's what the provider thinks is most probable. So there's some things to know about data collection. The first thing to know is that there are two general categories of information that is collected, and that is the signs and the symptoms. And we often talk about them as if they're one kind of thing lumped together, and in a way they kind of are, but it's important to understand the difference. A symptom is a manifestation of a disease apparent to the patient, while a sign is a manifestation of a disease that the provider can perceive. This means that the sign is objective evidence of a disease. A symptom is a subjective symptom, I mean, subjective experience. So it's important to know that signs are considered more reliable than symptoms. And this is because research has shown that people generally don't make very good historians and don't do well in keeping track of what's actually been going on. Most of the time, a patient can't tell you the timeline of events. They can't tell you how long a symptom has been lasting. They're not really good at associating, is their symptoms exacerbated or alleviated by things. I mean, generally speaking, the truth is that human beings are not good historians. And this is why I feel that a medical journal is an immensely valuable tool that can give more credit to your personal report. It can help you provide better, more concrete data to your provider. And it is a way to document what you're experiencing that can add some reliability. The other thing to know is that most of the time, the presenting signs and symptoms can be caused by a multitude of things. And this is why a differential is created. Most providers also list those possible diagnoses in order of how likely they feel that it is that diagnosis. And basically, they're going to start by looking for the horses before they start looking for the zebras, even if you have signs and symptoms that fit criteria for both. They're going to look for the things that are more likely to be present. They're going to look at statistics. This is the biggest reason that getting a diagnosis can take a long time if you have a rare or uncommon illness. And it's because you have to be looked at for all of the common stuff before they even consider the rare and unusual things. They're not going to consider that you're a zebra until they've pretty well established that you're not a horse. So the more possibilities there are to rule out, the longer this process is going to take. So it depends on what your symptoms are, but because there's some symptoms that just have a lot more possibilities. So once they have the differential, they're going to decide which diagnosis to start with, and then they will order tests that will help them to determine if that is in fact the diagnosis or not. And once the data from that testing comes back, they're going to reassess all the data and determine if they think that the diagnosis they were considering still makes sense in context of the data from the testing. If it does, you get that diagnosis. If it doesn't, they move on to the next diagnosis and do more testing. So the thing about the majority of medical tests is that they are not going to give you definitive answers. A positive result on a test usually indicates that body is functioning a certain way, and that can often narrow down a diagnosis, but it rarely only indicates a single diagnosis. There are a few tests that work this way, but that is not the majority of the time. It is also important to know that every type of medical test can have a false positive and false negatives, which can further confound the diagnostic process. Sometimes these inaccurate results are because the testing occurred too soon, or the levels in the body haven't reached a detectable threshold. Sometimes it's because the angle of the imaging wasn't what was needed to see the abnormality. Sometimes it's a matter of interpreting the results. Sometimes the problem is that you, whatever it is you're trying to test for, just wasn't actively happening at the time the test was conducted. So the point is that these medical tests are complex and need context to be meaningful, and that testing unto itself is not always definitive, and it doesn't always lead to the right answer. The real diagnosis. So sometimes testing can just convolute the matter more. It can make things more complicated. It is how we go through the diagnostic process, but it isn't as streamlined and as simple as it might seem. The other thing to keep in mind is that there's plenty of room for a provider to have a treatment style. There are a multitude of, there are pretty much three. So the first style is to nail the diagnosis. You focus on getting the diagnosis. And the second style is to make the patient comfortable. And the third style is kind of a blending of these two, and neither of these styles, or 3 styles, is wrong. All the styles have their pros and cons, but it can really be helpful to know which style your provider is working from, as it can help make sense of their approach to your care. So the first style is all about making sure you get the correct diagnosis. The theory behind this is that the correct diagnosis will increase the probability that treatment is going to be benefiting the patient and won't cause harm. With this approach, the provider is not going to start any kind of a treatment until they're really, really sure of the diagnosis. This is because they don't want to skew any of the results with any treatments they've started, nor do they want to cause things to get worse by starting treatments without being sure of your diagnosis. The pro to this style is that you're more likely to have a good outcome because you're more likely to get a good, accurate diagnosis. The con is that the patient is likely to be waiting longer to receive any kind of treatment. The second style is all about addressing the symptoms that are bothering the patient. The theory behind this is that the diagnosis isn't the most important thing. Getting the patient to wellness is. With this approach, the provider will start treating the patients as if they have the most likely diagnosis, in the hope of improving the patient's condition while they begin testing and trying to narrow down that diagnosis. They're going to focus on making the patient more comfortable. The pro to this style is that the patient gets immediate treatment and often gets relief from troubling symptoms rather quickly. The con is that treatments can skew testing results or even make the condition worse if the presumed diagnosis is incorrect. So the third style is a bit of a middle ground, and this approach reserves the majority of treatments until their diagnosis is sure. And what treatments are provided prior to securing a diagnosis are those that focus on stabilizing the patient, have a low risk profile, and address high comfort needs, issues like shortness of breath and pain. This style has the pros and cons of both the first and second styles, and the majority of providers work within this third treatment model when you're talking about the hospital setting. So if you have been hospitalized, or you're in an ED, or if you're in a outpatient urgent care clinic, the third style is what you're most likely going to see. The provider is going to have the primary focus on figuring out what's going on, and they are going to do some treatments to alleviate really high comfort needs. But for the most part, they're going to wait until they know what that diagnosis is. So the last thing to keep in mind with all of this is the general patient prognosis. There are many times that a diagnosis is simply not pursued because knowing the diagnosis is not going to impact the patient's care. So say that the patient is nearing end of life, and when doing a chest x-ray to evaluate the patient for aspiration, the provider discovers that the patient has a lung mass. If the patient would not be a candidate for treatment or would not elect for treatment for this mass, then it really doesn't matter what the diagnosis for that mass is. This is a really dramatic example, but it just makes the idea clear. Just know that most cases of prognosis are way more nuanced than that, but it is kind of important to know that the provider may begin by having a discussion of whether or not there is even benefit to having a diagnostic workup. Like say with dystonia, is it really relevant to know whether or not you have the genetic form of dystonia that's responsive to the dopamines? It's not going to change your treatment course. I mean, they can just give you a trial of the Sinemet and see if it works. If it does, then you have dopa responsive dystonia, and that knowing that you have that gene isn't really going to change your treatment course. So there might be a discussion as to whether or not doing genetic testing has any value for you. Would it change your diagnosis? Yeah, it would. But does changing that diagnosis have any clinical meaning for you? Not really. So there are times that the patient prognosis and the meaningfulness of the diagnosis can be discussed. So in the end, I feel that it's important to know what you value as a patient. How important is it to you to know the diagnosis? Should you know the diagnosis before you begin treatments? How do you feel about this? Don't be afraid to discuss these issues with your provider, and keep in mind that what makes sense to you in one medical situation might not in another. So it's not always going to be the same for you. The most important factor for ensuring that you are getting the best possible care is to maintain open lines of communication with your provider. And this is true here too. Be sure that you're asking them all your questions, and don't be afraid to tell them when you're not comfortable with the treatment plan that they're proposing. There's sometimes they're going to put options on the table and you're just like, "Ugh, I don't know about that." Or I really wish I knew the diagnosis before we pursued treatment. Those are important conversations to have with your provider to make sure that you and your provider are on the same page throughout your treatment course. So in the world of the internet and getting information from Google and other chronic illness warriors out there talking to each other, we often go into our appointments with expectations and sometimes even with self-diagnosis. There are some things to keep in mind about this. First, the internet is a powerful and a great resource, and I am going to encourage everybody to do what they can to learn about their symptoms, to learn about their diseases. But I'm also going to encourage you to be sure that you're getting your information from sources that are credible. If you want to look at actual research, use Google Scholar, but you can use reputable sources like medical providers, medical institutions, but just keep in mind that these are going to be clinical opinions of groups and individuals. So the other thing to kind of keep in mind is that it's entirely possible that your provider isn't going to agree with your self-diagnosis. And for many providers, this is a really big point of frustration. But if they don't agree with your self-diagnosis, be sure to ask them why they don't think that this diagnosis is correct, why they don't think that it's worth pursuing. They should be able to explain to you why the data led them to a different diagnosis or a different exploration path. And you have a right to understand how they come to their conclusions. Don't be too quick to shoot them down just because they come to a different conclusion than you do. You are the expert of your body, but they're an expert in medicine, and there's value in that. Both have an important and a valuable perspective, and I think that medicine works the best when both those perspectives are fully integrated into the treatment plan and we're working as a team. So keep an open mind to a different perspective. Don't hesitate to talk to your provider. It's super important to understand their thinking and their thought process when they're going through a diagnostic and a treatment course. So yeah, talk to your providers. So that's about it for my rambling today. Thanks for coming and spending time with me. If you like the video, please click the like button. It does help. And until we talk again, you guys take care of yourselves.